Sir, we are live now. With all your permission, I am starting this session.
Okay.
A very good evening to everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Professor Nishant Kumar, sir. Let me share some of the achievement of this sir. Sir has done MBBS, DA, DNB, MNAMS, professor at the Department of Anesthesiology at Lady Harding Medical College, Associated Hospital. And today sir is going to discuss on a topic, static and dynamic parameters in hemodynamic monitoring. Let me share some overview of the topic. Static and dynamic parameters in hemodynamic monitoring are crucial for accessing a patient's cardiovascular status. Static parameters such as blood and central venous pressure offers insight into the baseline condition. Meanwhile, dynamic parameters like pulse pressure and stroke volume variation provide a real-time data on fluid responsiveness and cardiac function. To know more about this topic, I would like to invite sir and hand over this session to sir. Sir, over to you, sir. Kindly proceed from here.
Good evening. I'm sorry for the disturbance. Actually, the thing is that I am in the city of enlightenment, Gaya. So I thought that I would do this talk right from under the Bodhi tree, but unfortunately, mobiles are not allowed there. So I'm doing it from outside. I'm sorry for the noise, background noise, but I hope my voice is loud and clear. So today we'll be talking about the static and dynamic parameters in hemodynamic monitoring. We all know hemodynamic monitoring is important in ICUs and OTs, and there are various parameters which can be undertaken. So first we have to understand the basics of the hemodynamic monitoring. Next, please. Yeah. So why do we need to monitor? So we need to monitor the hemodynamics because that is what ensures adequate blood supply to the tissues. And in the ICU, the major aim is to maintain a mean arterial pressure of more than equal to 65 millimeters of mercury. Now, if the map is less than 65 millimeters of mercury, we usually call it as hypertension or shock. And usually there are three reasons for that. A failure in the pump, that is the heart, as we all know, that the heart supplies the blood to the various tissues. So if there's any inadequacy of the heart, that is the pump, there's less of forward flow. The tank, the venous compartment, that means vasodilatation and shock because there's not adequate supply to the pump. So that will cause a hypertension, or the pipes, aorta, just like aortic dissection, or again, severe arterial vasodilatation. So naturally we'll require inotropes for that because the pipes are the conduit through which the blood is supplied to the tissues. Now, the main thing is that the traditional concept has been to maintain the pressure. So that means that if the pressure is adequate, the flow will also be adequate. But now our paradigm is shifting from pressure to flow. That means it is not only the pressure, but the flow also, or the volume also, which has to be monitored. Next, please. So, on the basis of monitoring, we decide what intervention we have to do for which disease. For example, for the heart, we might have to give the inotropes. For the tank, that is venous compartment or shock, we might have to give fluids or vasopressors. Now, again, the question arises, when to give fluids, how much fluids to give, and when to stop, or when to start your vasopressors. So again, it is a choice between the fluids and vasopressors that we decided on your hemodynamic monitoring. And for the aorta, you might have to give fluids for vasodilatation. Vasopressors, again, if the fluids do not maintain the map and the forward flow, and if there is too much of vasoconstriction, you might even have to administer vasodilators to maintain the flow to the tissues. So ultimate aim is to maintain the oxygenation of the tissues by maintaining adequate blood flow. Next, please. So when we talk of the heart, we all have heard about the Frank-Starling law. That is the capacity of the heart to significantly increase its stroke volume or cardiac output in response to volume challenge. That means that the more volume that you give, the more the heart will contract and there will be more forward flow. But that works under a physiological limit. That means that if the heart dilates or if it is too much of fluid that you have given, the heart will fail. Compare it to the spring. When you compress a spring, it bounces more. But if you stretch it too much, the flexibility or the bouncing ability of the spring loses. That is basically an analogy to the Frank-Starling law as it applies to the heart. So as you can see in this, yeah. So as you can see in this, if you see this, this is a heart, and as you give the bolus, that means that the contractility decreases even if you increase the fluids. Next, please. Okay. So we might have the static indices. That is, once is not enough. That means that we monitor it, and the main thing is that fluid will depend on the heart-lung mechanics. That means during the various phases of respiration, inspiration, and expiration, the blood volume that comes to the heart and goes out of the heart varies. So basically, we have to understand the heart-lung mechanics. We all know as the intrathoracic pressure rises, the venous blood flow decreases. So we have the static indices. That means that they do not take into account the heart-lung interactions. Next, please. So the most commonly used static indices are lactate. Now, we all know that lactate is a marker of tissue hypoxia. But yes, there is a lag time. That means that hypoxia has occurred in the tissues and lactate will increase after some time. So it is not instantaneous. And again, when you have administered fluid, when you have restored the fluid, when you have restored the oxygenation, the lactate may not come back to normal immediately. So there is a lag time, and again, it does not depend on the degree of hypovolemia. So that means that whether the patient has lost 500 ml or 5 liters, you cannot quantify, okay, this much fluid is required for this value of lactate. Or if you give this much of fluid, the lactate will decrease by this much value. Okay. The other one is pulmonary artery wedge pressure. Now, this is considered gold standard for left ventricular preload. But yes, again, we are not actually measuring the left ventricle. What we are measuring is the pulmonary artery pressures. So that means that if there's any pathology in the lungs, there's any pathology of the left side of the heart, the pulmonary artery wedge pressure provides a very poor correlation with the left ventricular end-diastolic volume or the volume status of the left ventricle. So there are a lot of assumptions that we take into account when we are inserting a pulmonary artery catheter. Again, pulmonary artery catheter itself is not considered very safe. There are a lot of complications. It is not easy to insert. And you have to be really an expert to insert a PAC and interpret its finding. Next, please. So, ultrasound evaluation. Now, ultrasound has brought about a revolution in ICU and OT. So, we can actually visualize the three things that we said, the pump, the tank, and the pipes, and isolate the pathology. So, basically, ultrasound is to find out the pathology. So, for the pump, it might be pericardium tamponade effusion. Initially, you have to go with fluids and do a pericardiocentesis. If the left ventricular size, that is a cardiogenic shock, you might have to give inotropes. Agar right ventricular size failure or PE, again fluids or specific therapy. Okay. For the tank, that is, we have to see in the IVC whether there's a hypotension shock, whether fluids are required or not. Then lungs, pneumothorax, edema, effusion. Then EFAST for any collection in the abdomen, which might be pushing up and causing hypotension. Similarly, for the pipes, we have the DVT, aortic dissection, any DVT which is there, which might have caused a PE. So ultrasound is a very good tool to assess the underlying pathology, but then again, it's a static. It does not give you the dynamic parameters, and it will tell you once, okay, this is pathology, now you treat it, and then you have to keep on repeating it. Next, please. So the mainstay of hypertension or shock remains administration of fluids. So when should the fluids be started? Should I start the fluids? How much fluid should I give? And for how long should I give? So these are the common questions that we have to ask. And ultimately, the dynamic parameters are there to answer these questions, which if we use the static parameters, we would ideally give either too little or too much of fluid. So that is how we decide on these factors. Next, please. So what is fluid responsiveness? Fluid responsiveness means that when we administer a bolus of fluid, there is an increase in 10 to 15% in the cardiac output. Now, remember, the static parameters never talk about cardiac output. We have been talking about CVP, we talk about pulmonary artery wedge pressures, we talk about other parameters, but never the cardiac output. So the cardiac output is the thing which is the dynamic parameter, which will tell you whether the flow has increased or not, rather than just the pressure. So, but an increase or fluid responsiveness does not always mean that fluid is needed. Up to 50% of the ICU patients may be fluid unresponsive. You administer fluid, but there wouldn't be any change in the cardiac output, although the static parameters might improve. So, just like antimicrobial agents, antibiotics, we have to usher in fluid stewardship. So that is very important. Now, with antimicrobial stewardship, the new thing in the ICU is fluid stewardship. As I said, when should I give fluids? When should I give fluids? How much fluid should I give? And when should I stop? So again, the clinical parameters that we have been talking about, urine output, mean artery pressure, and they show a lag. So that's why we do a dynamic test, or we give a challenge and then see whether there is a change in the parameters or change in the cardiac output or not. So that is what is dynamic parameters. And what is fluid tolerance? Fluid tolerance means the ability of the patient to accept fluid, and there is no harm when this extra fluid is administered. So that is fluid tolerance. Next, please. So why should we perform a fluid responsiveness? As I said, not all patients, even in shock, are fluid responsive. As I had listed above, there are many reasons for the shock, right? So the SSC guidelines say that you administer this much of fluid over this much period of time. But then 38% were fluid non-responders. That means even if we gave them fluids, their parameters did not improve, the tissue oxygenation did not improve, the MAP did not improve, and we might have actually caused harm in these patients. Next, please. So when to perform a fluid challenge, fluid resuscitation test? So patients presenting with septic shock, initially you infuse around 10 ml per kg within the first hour. So that is the surviving sepsis guidelines. So you decrease infusion rate in case the clinical features are worsening, or there's a fall in oxygen saturation. And you can increase the infusion rate in cases of evident fluid losses. Obviously, if there's evident hemorrhage, then you obviously keep on giving fluids. If there is mottling, increased capillary refill time, low arterial pressure, fever, or abdominal origin of sepsis. Now, again, so this is the initial challenge. And if the shock persists, we see whether the fluid will help the patient or not. So the things that we have is stroke volume variation. I'll be talking about these, the pulse pressure variation, and the tidal volume challenge. These are all dynamic tests. And passive leg raising test, which is very easy to perform and will not cause any harm to the patient. So, and we can also do an end expiratory occlusion or IVC diameter variation. Now, these are all dynamic. These will tell you whether the cardiac output is increasing or not when you administer fluid. So if the patient is preload responsive, so in ARDS, you see whether you can administer more fluid, whether the fluid is going to cause benefit or harm. If the patient is without ARDS, you consider another fluid bolus. And if the patient is unresponsive to fluids, that means that these parameters do not improve once you have administered fluid. You have to consider other therapies. Now, SSC also says, surviving sepsis guidelines also says that 30 ml per kg over first 3 hours, it's a weak recommendation and a low quality of evidence. So by giving so much of fluid, we might actually be causing harm rather than benefit to the patient, right? So whenever possible, please, dynamic parameters have to be performed so that we can have a better performance. Next, please. Yeah. Okay. So Fluid responsiveness is not a fixed phenomenon. So if you see at T0, 76% were responsive, but at 30 minutes out of this thing, out of the total of 143 patients, only 43 remained responsive. So the responsiveness also changes. Within the first 30 minutes also, the fluid responders, I mean the patients who were improving with fluid therapy, did not respond to the fluid therapy at the end of 30 minutes. So that is the problem. So that is why that dynamic and continuous monitoring is required rather than singular and static measurement. Okay, next please. So what are the dynamic indices? Now dynamic indices can be singular or continuous measurement. Next please. Again, as I said, why a dynamic response? Because we might give too little or too much. There's a lag time with downstream parameters such as lactate and SCVO2 even. Whether the patient really requires fluid or requires vasopressors or inotropes. And if this patient is fluid responsive, how much to give and for how long to give the fluids. Next, please. So increase in preload does not always means that the tissue perfusion will be improved. It is a stroke volume which needs to be increased, and excess of fluids, as I've been saying again and again, may be harmful. So we have to assess the intravascular volume, keeping in mind the heart-lung interaction, that is the various phases of respiration, how the respiration will affect the flow of the fluid in the pipes to the tissue. So that is dynamic. Again, it can be a continuous monitoring or it can be a challenge-based monitoring. Next, please. So if we just see the IVC diameter, that is a static this thing. Okay, it is collapsible, not collapsible. There is no what do we call it, interaction with the respiration. But when we see the distensibility and the collapsibility index in spontaneously and mechanically breathing patients, in the mechanically and spontaneously breathing patients, so an IVC diameter index, the distensibility or the collapsibility index of more than 18% tells you that the patient will or may benefit with administration of fluids. So remember, just looking at the IVC diameter and collapsing rate is a static index, wherever when we do the distensibility and the collapsibility index, it is a dynamic index. Next, please. Yeah. So the others are with minimally invasive and the other ones non-invasive. We have the pulse pressure variation and the plethysmographic variation, stroke volume variation, and pleth variability index. Now, the advantage of pulse pressure variation and pleth variability index is that it is reliable in prone position as well. So as you can see from these graphs, that what it does is we see the PP max, the PP minimum, and divided by the PP mean to get the pulse pressure variation, and we take the SVX, the SV max, stroke volume maximum, and stroke volume minimum, and then we divide it by stroke volume minimum to get the stroke volume variation. Now, see that these things are, it can be invasive or non-invasive also. Stroke volume variation can be calculated from the plethysmograph also. So that is called as pleth variability index. Now, if you see this graph, as you can see in this graph, these graphs will tell you about the area under the curves gives you the stroke volume, whether it is the plethysmograph or the arterial waveform. So you need not actually catheterize the heart or the left ventricle, but just by an arterial line or by the SpO2 probe, you can calculate these indices, and more than 12%, the patient requires fluid, and then you see the change in percentage. Next, please. So one thing that we can do is we can give a challenge and we can find whether the patient is improving or not, the parameters are improving or not. The challenge and thou shalt find. Next one, please. The simplest one is a passive leg raising. So normally the patients are nursed in the ICU in a semi-recumbent position with a 45-degree head up. Now all you have to do is just reverse the patient, make the patient supine and make the legs raised up to 45 degrees. So what will happen? So another 1 to 1.5 liters of blood, which is pooled in the veins, will go into the heart directly. Okay, so that is a challenge. You're not giving any extra fluid, and it can be easily reversed. You reverse the position because of the gravity. Again, the fluid will come back into the lungs. So that will tell you whether the patient will improve when you give a fluid bolus or not. So that is a very easy and simple test that you can perform. And again, the parameters that have to be observed are the cardiac output, the stroke volume, or the stroke volume variation, SPV, and PVI, or the collapsibility and the distensibility indices rather than anything else. The next one, please. So, as we know that fluid bolus of 30 ml per kg over 3 hours may actually harm the patient. So what we can do is we can deliver a micro or a mini bolus. A mini bolus, a micro bolus is 50 ml over 1 minute, and micro bolus is, micro bolus is 50 ml over 1 minute, and a mini bolus is 100 ml over 1 minute. So again, you see the dynamic parameters, that is stroke volume variation, the cardiac output, or your other tests, whether there's an increase or not. One of the tests that you can do is end expiratory occlusion. So now the patient should not be spontaneously breathing, should be paralyzed. You do a 15-second hold at end expiration. If there's a if the end tidal carbon dioxide increases by 5%, that means that the cardiac output has increased. So that is how you see. Next one, please. I'm sorry, the end expiratory, can you go to the back one, please? The previous slide. Yeah. So end expiratory occlusion is you occlude. So that means what will happen is that after the administration of fluid, when you are this thing, a 5% change in cardiac output will tell you whether the patient requires fluid or not, because that is a PEEP that you have applied and the venous return has decreased. So that will tell you if there's a change in cardiac output by 5%, that means that the patient will require fluids. Next one, please. High PEEP challenge. So we increase the PEEP by 10 to 20 centimeters of water. And if the cardiac output decreases by 10% or the MAP decreases by 8%, now again that will tell you that the patient will require fluid. So it is basically the same as an expiratory occlusion, but here we are calibrating and giving a PEEP, a high PEEP, to see whether the cardiac output decreases or not. Similarly, we increase the tidal volume from 6 to 8 ml per kg to 10 to 12, up to 12 to 14 ml per kg. So a pulse pressure variation increase of 3.5% will tell you that the patient requires fluid. And again, it is reliable in the prone position. Next, please. Similarly, end-tidal carbon dioxide can be used, EtCO2 can be used to ascertain whether the patient is responding to fluids or not. Remember, as the cardiac output increases, the delivery of carbon dioxide to the heart, to the lungs increases, and EtCO2 increases. So a more than 5 mmHg in response to passive leg raise tells you that the patient is fluid responsive. Again, cardiac output and cardiac indices increase by more than 10 to 15%. Whether you do it by LITCO, PICO, flow track, non-invasive ISCO, pulmonary artery catheter, or non-invasive cardiac output monitoring, doesn't make a difference. Any increase in cardiac output by 10 to 15% by giving fluid means that the patient is fluid responsive. Other things that can be used, we can do it by passive leg raise, we can give a bolus, we can do an end expiratory occlusion, or we can do a PEEP challenge without actually giving the fluid. However, continuous cardiac output using pulmonary artery catheter still remains the gold standard. Using the ultrasound, we can see the LVOT and carotid VTI. And if the respiratory variation is more than 20% and beat-to-beat variation is more than 12%, that means that the patient is fluid responsive or will benefit from fluids. Now, VEXUS is another ultrasound marker which will tell you if you've given too much of fluids. Next, please. So, The things that you have to do, this is a very simple flow chart. Is there an acute circulatory failure? So you will have low blood pressure or cardiac output, signs of tissue hyperperfusion. Okay. So if the hypovolemia is obvious, obviously you give fluids. If no, then you check for preload responsiveness. If the patient is spontaneously breathing, there are cardiac arrhythmias, or if the patient is having ARDS with low tidal volume and low compliance. Next, please. In these cases, you do a passive leg raise test or an end expiratory occlusion test or a mini fluid challenge. Why? Because your pulse pressure or stroke volume variation, respiratory variation of IVC or SVC, and expiratory, the other things, these may not be reliable. But yes, you can do the passive leg raise test and expiratory occlusion. You can do the pulse pressure variation, stroke volume variation, and the IVC distensibility collapsibility index if these conditions are absent. So if the these tests are positive, you give fluids. If not, you do not give fluids. You consider other therapies. Next, please. Okay, echo. Echo can again tell you whether you have to give fluids or not. So you see the signs of overt hypovolemia, that is kissing ventricles, small hyperkinetic left or right ventricles, so small collapsible IVC. And again, you have to see whether there are any limiting conditions. Next, please. If these conditions are not there, consider fluid challenge if fluids are indicated clinically and with any of the following, that is SVV more than 12%. We have the LVO TVTI velocity with respiratory variation of more than 20%. Beat to beat LVO velocity change of more than 12%. IVC distensibility index of more than 18%. So, if these conditions are not met, you can try the micro or mini bolus, and you see again the LVOT VTI, right? And if there are conditions which say that the echocardiography parameters might not be correct, so you do a fluid challenge clinically, if indicated clinically, and then you see the LVOT VTI increase of more than 12% with PLR without administering any more fluids, right? So you can see the filling pressures, whether the fluid has been given too much or too less by EA ratio, E by E dash ratio, and S by D ratio. And these will tell you whether you're making the patient prone to pulmonary edema or not. Okay, and we can keep on giving fluids and keep on reassessing, but then again, it is time consuming and you require expertise for that. Next, please. We can do the false protocol. We can rule out the obstructive shock by the blue protocol, that is pneumothorax. We rule out the cardiogenic shock by pulmonary edema B profile, hypovolemic shock by correction of parameters under fluid administration. That means that the moment the B lines start appearing, that means that you have given too much of fluid. And you can detect the distributive shock and septic shock currently. That means that if you keep on giving fluids, the B lines are increasing. Next, please. So now we have the AI in everything. The future is that machine are taking over. Next, please. So what we have is the hypertension prediction index. This is a machine learning algorithm. It takes into account the pulse pressure variation and stroke volume variation ratio, displays mean arterial pressure, CVP, cardiac output, stroke volume, systemic vascular resistance, and other indices. Now, this is a number. This gives you a number. The moment that the number reaches 85, that means that in the next 15 to 20 minutes, there is a likelihood 85%, 88 to 92% chances that the map will go down below 65 mm of Hg. And based on these parameters, whether it is a CVP, cardiac output, SV or SVR, that means appropriate therapy has to be initiated, be it fluids, be it vasodilators, be it vasopressors, or be it inotropes. So based on this, next please. So this is what it looks like. You have all the monitors and all the values, and it gives you an indication. You can see the SVV. Green means that everything is fine. Yellow means that it is caution, and red means that something is amiss. Next, please. So a simplified physiological protocol is that if the SVV is more than 13%, that means you give a volume challenge. If the SVV is normal, right? So you look at stroke volume index. That means that there's a problem with the contractility. You will give a pressure. Sorry, if the SVI is normal, if the SVI is low, that means that there's a problem with the contractility. You'll give an inotrope. If the SVI is normal, that means that the heart is okay. The problem is with the pipes. So you'll give a pressure, vasopressor. And if the SVI is high, that means the SVR is high. Then you have to give a diuretic. That is how with the machine, and on the basis of these parameters, you can decide what to give when. Next, please. So that brings me to the end of this talk. I hope I have simplified it, and I'm again sorry for the background noise which was there and the dark camera which you had to face. Thank you so much. I'm open to questions.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. And I would like to thanks more because, sir, you have taken out being in a not a condition to deliver the speech. Still, you have for the participant, you have agreed and giving your
No,
valuable
I had
time, sir.
promised, so I had to keep my end of the promise. So
Exactly, sir. That is the main important part. Like whenever you are, where you are, but the thing is, you have already given the time. You are delivering the things, sir. Thank you so much for this. I hope that participant also understand these things. Like dedication towards teaching is very important. Sir,
thank
as
you.
we can see, sir, we have received a very good question, sir, from the participant end. And if you allow,
Okay.
sir, can I take this question with all your permission?
Yeah, sure. I'm switching off the camera so that I can use the phone part, if that is
Okay, sir.
okay.
Okay.
Yeah.
Okay, sir.
Okay.
Sure, sir.
Yeah.
Sure, sir.
Yeah. Tell me.
Yes, sir. The question is from Dr. Subramaniam. He is asking, what is the difference between static and dynamic indices of fluid responsiveness?
See, as I told you, static will not tell you about the heart-lung interaction. The dynamic are more reliable and will tell you whether actually the fluids are required or not. Static will have a lag time, and by the time you give fluids, you might have caused harm. So that is the thing. So dynamic will give you an exact thing whether the fluids are required or some other therapy is required.
Okay, thank you so much, sir, for answering. I hope that Dr. Subramaniam has received his answer. And I can see Dr. Ayushman is asking, does an increase in cardiac index after fluid administration mean providing the DO2? Is it not always the case?
See, again, we are making a lot of assumptions. Now, the latest knowledge says if we can actually measure the DO2, that is very good, but then that remains elusive.
Sir, you are on mute now. I think sir is facing some problem. He will be joining us. We got disconnected. I request all the participant doctors, if you have any question related to this topic, you can be here and just keep the questions in the comment box so that we can deliver this question to sir. I also thanks all the participants for joining on this session and making this session informative one.
Hello, I'm sorry I got disconnected. Can you hear me?
Yes, sir, I can hear you, sir.
Yeah. So to answer the last question, DO2 may not always improve. We are assuming a lot of things. We can actually do a submucosal oxygen monitoring, but that is again in the experimental stages. But we assume that if the cardiac output is increasing, the DO2 is increasing, but that may not always be the case.
Thank you so much, sir, for explaining this question, sir. We will be taking last question for today's session. From Dr. Snehali. She's asking, what are the effect of static and dynamic measurements using transposition primarily thermodilation devices on fluid therapy in septic shock?
See, as I said again, with these devices, what you're doing is you're measuring the cardiac output. Now, with thermodilution methods, we are again assuming a lot of things because the fluid is administered on the right side of the heart, and we assume that the right will mirror the left. So, unless until we do a thermodilution wherein we do the continuous cardiac output, wherein we inject the thermodilution from the pulmonary artery catheter, and then we measure the cardiac output through the arterial waveform. Again, we are assuming a lot of things if we just do the right side only, just from the pulmonary artery catheter. But yes, if we do it from the pulmonary artery catheter and we measure through the peripheral artery, then yes, we are getting a global function rather than the isolated left ventricular function. Now, the isolated left ventricular function can only be ascertained from TE or TTE, transthoracic echocardiography, but then it is you have to repeat it and it is not continuous.
Thank you so much, sir, for answering all the question. I hope that all the doubt of the participant doctor has been cleared.
Yeah.
For sparing your valuable time on our platform, sir. As sir, I can see there is no more question from the participant end. Sir, with all your permission, shall we conclude this session?
Yeah, please. Thank you. And I'm again very sorry because I didn't want to change it at the last minute. So I'm very sorry for the background noise.
Okay, no problem, sir. It was really great. Like, thing is that people are able to get the knowledge what you have shared, sir, during this
Yeah.
presentation. And hope to see you, sir, again with different topic in coming time, sir. Till then, take care of yourself, sir. Have a great, sir, like a journey at Bodh Gaya, sir. Once again.
Thank you.
Bye,
Thank you.
sir.
Thank you
Have
so
a
much.
great day. Good night, sir.